Yeah, no, thank you. I would like to say that, when it comes to routes of administration, I'm the kind of clinician that feels like there's pros and cons to all of the routes. I've heard some providers out there say, IV is where it's at. You can only do IV. And I've heard many other practitioners say intramuscular is great. Why would you even bother with IV? And so at our clinic, we offer IM, IV, and lozenges. And I like working with different routes because you really can see firsthand that there are advantages and disadvantages to each of the routes. I kind of thought in working with trauma that IV might be the way to go because it's often noted to kind of come on much more gently than IM. But I don't think that's always the case. With good preparation and starting at a more conservative dose for the first session with a patient with trauma, like many of you, we start with 0.5 milligram per kilogram dosing, and I kind of refer to that as usually a test dose for most patients. Because for many people, if you only stick with that dose, it's going to be inadequate for the course of their treatment for PTSD or for depression. And then one other thing I found kind of interesting is what you said, Abid, is that you've noticed that higher doses ended up being required to really effectively treat PTSD. So it's so interesting because a lot of clinicians talk about, well, stay with lower doses. Lower doses is safer. You're less likely to activate the person or cause uncomfortable dissociation. And don't quote me on this, audience. I could be wrong, but I believe if anyone's familiar with Carl Bonnet, he's a great ER physician, has clinics in Austin and San Antonio, and his clinic is Clarasana. And I think Dr. Bonnet published some results in treating PTSD as clinics, many of whom I think were veterans. And I believe the dosing was quite high. I mean, not dangerously high, of course, but on the higher end of the spectrum. Maybe like the range you said, Abid, like maybe between 1.5 to 1.75 mg per kg. So that may be something that needs to be explored, as people try to do this work more and publish their results or do some research that higher doses may in fact be better for trauma. So we still have a lot to learn.
I think Dr. Bonnet, I think if I remember right, his study, they had gone up to like even 2 milligrams per kilogram, which is really high, and we don't really do that very frequently, and we work our way up to those higher doses. But it's like I said, some people, they will need that higher dose as they continue their work in each session, and kind of have to work your way up to it. But that's where I think a little, if you plateau on your dose, sometimes you'll start seeing after some time that you're not getting as long of a maintenance interval between, each treatment. So what do we do next besides optimize meds and look at all the behavioral changes? I mean, one of the things we can do is try to pump the dose up for handling it.
Yeah. Okay. Next, kind of a different angle on this. I'm curious to hear if y'all have noticed any specific kinds of problems that arise when you work with folks with PTSD and trauma. So if certain problems arise during the therapy or related to the effects of the medicine itself, obviously we've been talking a little bit about dissociation, feel free to talk more about that. But any experiences, that are very notable for y'all that you think are worth sharing? And if so, how do you address these problems that come up? Tatiana.
So I haven't seen the problems yet because I believe that once the client is really well prepared, even if the problems or challenging experiences come up, they know they're prepared well. And I noticed that clients tell me, like I was struggling to let go, but then, and because you explained it to me ahead of time, it was much easier. So I think it's creating the sense of safety, encouraging the patient to be curious about what comes up, and having a good experience with all aspects of care, I think contribute to creating the sense of safety. So even from the beginning, from when they enter into the clinic or from before that, when they contact us, to the whole entire experience with staff, with the clinic, with all of us, I think that creates the sense of safety. And then the challenges, I believe, would be the the internal challenges. But if we're there to hold that space and provide safety, so far I have not seen the challenge yet.